Just a few words about myself. I am a clinician. I consider myself to be a clinician, even though I've been working primarily academic for the last 8-9 years. I always keep coming back to the clinic, and I do see patients still, not on an everyday basis, but I see patients every week. And everything I'm sort of doing is related to how to manage patients. And the primary patient I would see is the sort of complex pain patient, whatever you call it, who has been struggling to get to understand what their pain is all about, how to predict how their lives are going to be, and basically to get on with their lives. And they would usually have done loads of treatment before. So I'm just giving you this as a background to understand where I'm coming from. So today's talk, we're going to take and look into pain education, and I don't want to go into the details about pain education. I've just listed a few of the meta-analyses and systematic reviews on your left here to suggest that education is a relevant intervention. We should use it. I just noticed now that the picture I put up is in Danish, but it's taken from Butler Mosley's Explained Pain book, which I assume you'll be aware of. So it's a metaphor, it's a theory turned into a story about how you can talk to the patient about their pain. And that has really brought us a long way since 2003 when this book came out. But what I want you to do is ask yourself, why do I educate patients at all? When I ask myself this question, I would say, well, the patients feel better when they know how to biologize their pain. I would suggest that. I also think that sometimes educating them about pain might even reduce it. And I also think that there's something I know which would be relevant for my patients to also know. The thing is, if we look at the data, it doesn't really support this. There's not really good evidence to suggest that there is a consistent pain reduction by education itself. A large study done by Traeger and Mosley's group not so far back suggested that you can get a similar effect if you have patients that are just being asked to talk about their problems and being guided basically with a sort of motivational interviewing approach. So just listening to the patient might actually be beneficial for many patients in acute pain, and I would suggest in chronic pain as well. I don't know if you're aware of this video, otherwise I would encourage you to go and watch it on YouTube. So it's this girl talking about the nail in her head, but she keeps coming back to it's not really about the nail. I like the story here because it sort of ties into what I'm going to say, that it's not necessarily, once a patient is living with pain for a long time, it's not necessarily about the pain. It's about the compassion, it's about the understanding, it's about having social relations with people around you that is really difficult when you're in pain. So I was just recently at the European Pain Conference hosting a small workshop with patient advocates and patients and clinicians and some scientists. And these are 4 of the dots I took from that class or that workshop. So the patients would raise their voice and say it's patronizing to educators because we know pain better than you do. And of course they do. So what they really want, or what this one patient said they would really want, is our advice. But let us be, advising them, not telling them how to do it, because as they say, we know better. They also said that there is a big need for them to feel that we believe them. So when they say then pain, we don't need to be questioned. They don't need to be questioned by us if that's true. And the thing that really came out very clearly is also that living with chronic pain is really isolating people, stigmatizing them and making them disempowered. And I think this is where my talk today will focus. And there was another nice thing, that patients seems to be much more comfortable with the fact that they can live with pain, even using words such as chronic pain, than I find that many clinicians are. There seems to be this word out there that chronic pain is a bad thing and patients might believe it never goes away. But maybe what we should think is that might be our perception rather than theirs. What is really important for the patients, though, is that they know that even if they learn to live with it, it's not just a metaphor, it's not just a story. And once they know it, they can live their own lives. That is not how it works. patients really want to be part of a team with us and know that they can come back for advice. I'm really a big fan of David B. Morris's book, The Culture of Pain, and I just recently found this Pain Dominion and another thing he wrote back in the early 90s. It's a free PDF, you can get it online. I just took out some part of it here where David Morris states that pain is more than a medical issue. I think we all are aware of that now. And pain has historical, psychological, and cultural dimensions to it. And the meaning of pain is often fundamental to the experience of pain, of course. And then what we think and how our culture, so how our society thinks about pain, not just their pain, but pain in general, and maybe in particular the pain that I feel if I was a patient, seems to have a real big influence on how pain is perceived by the patient. I tried to come up with this metaphor, so a graphic metaphor suggesting that there is something out there that will be the general understanding of what pain is, and that will change over time. 20 years ago, we were struggling telling patients to not stay in their bed if they felt bad, which suggests that maybe 35 years ago, 50 years ago, patients would stay in bed if they were hurting. We seem to have come, to a new understanding that even not just staying in bed is good for you, but actually being active might be the thing to do, or at least not being inactive. So within this contemporary understanding, a patient will feel pain, and they might, as I allude to here, have a fairly good understanding of the contemporary understanding. So if the society moves towards pain not being equal to harm, then it would be easier for the patient also to hurt and feel that it doesn't necessarily make them harm. But we also need to acknowledge that there are other people in this culture, this dimension. So all the people a patient would know, that would be their significant others, that would be, relatives far out, perhaps neighbors, colleagues at work, maybe employer. They would all have an influence on it, and their understanding of pain, again, would have an influence. So in the case here, where the patient has an understanding that is almost, covering the contemporary understanding, then that is probably a good starting point, and education might bring them further into the center. But we also need to understand that the patients, so the people around them, will have an influence. So what we really want to do is sort of move these two inside of the current understanding so that everyone's speaking the same language. I'm not by any chance suggesting that we know what pain is, but if we're not capable of talking about it, how are we going to then make it visible to others that it's not about the nail, or that it's not about how much pain I'm in, but really it's about how I feel. So I think that maybe pain education is also about helping the person in pain to communicate how they feel. I'm just going to draw a line out to the recent ICD-11, so the International Classification for the Diagnosis, including pain for the first time. So based on this, the chronic pain is now defined as pain in one or more anatomical regions that persists or recurs for longer than 3 months, and is associated with significant emotional distress or functional disability, and that cannot be accounted for by any other chronic condition. What that really means is that we will have something now in the new ICD-11, which ideally would be world standard as of January 2020, where you on the left side on this scale will have chronic widespread pain, probably best acknowledged as fibromyalgia. And if you look on the very right, you will have chronic musculoskeletal pain that is not orofacial. That's just a definition. But these will include your odd non-specific low back pain, the limb pain that people suffer from, like tennis elbows or Achilles tendinitis, if they fit the category before, so it's been going on for more than 3 months. It's my understanding from the references here and from people I've talked to and being part of the reference group here, that what is really happening is that we acknowledge that if things do not seem to improve within the first 3 months, chances are that if we keep doing what we've been doing so far, we won't get anywhere. So let me try and paraphrase that and say that again. If we have a patient with acute pain, doing what we normally do usually has an impact, and we would expect for the pain to disappear. That's what all the statistics say. So in general, acute pain go away. Most of us will have experiences with maybe low back pain, but it will only be a minority of us who will have recurrent low back pain that really has an influence on our social life and our physical activity. But in the new ICD-11, that would be considered chronic pain, even if it's only been going on for 3 months or thereabouts. So chronic pain is not about pain that cannot go away. Chronic pain is more about understanding that the normal approach, the linear approach, dealing with the tissues perhaps, is less likely to have an impact on the patient than what is normally seen in the chronic condition, where the intervention and the outcomes rarely seem to match up. So this brings us to the concept of being patient-centered rather than expert-centered. So let me start on the right-hand side of the slide with the expert-centered. If you, like me, was trained about 20 years ago, you would have a feeling that if you could just deal with the pathology, if you could change the pathology, if you could stretch the tissues, make the muscles less tense, make the cells go away, whatever, then the person would be healthy. We would, as professionals, be knowledgeable experts, so we would be expected from ourselves and from our patients perhaps to know better. And the patient is supposed to come to us and say, I have these symptoms, and we're supposed to diagnose them, and then we're going to remove whatever's wrong with them, and they will stop feeling bad. So the aim of our treatment is to cure their pain or their suffering. We would usually tend to talk about causal relations, such as there is a gene, there's a cell, there's a thought, there's a brain function that is causing this pain. And this is not an old thought, so this is still going on. There will still be lots of people suggesting that there is a linear relationship between what goes on in, for instance, the brain and how pain is perceived. But that means that it would have to be expert-centered approach, because only the professional knows about the brain, for instance, and how to deal with the brain tissues. Whereas if you go to the left side of the slide, the patient-centered approach is all about how the patient is affected by the DX is diagnosed and RX is treatment. So how does treatment affect the patient? Do they get better, or are they just not stopping it because they're afraid of missing out? They're afraid of missing out on a good treatment. Maybe the next treatment will cure them, perhaps. But also having a diagnosis such as chronic pain, how does that influence the patient? To really be patient-centered means that we need to expect and understand and also acknowledge that the patient is the expert. What that really means is that the patient has the autonomy to do exactly what they want, including goal setting, but I'll come more back to that. And we need to embrace the role as counselors and supporters to give the advice and to make sure we're there, but also to acknowledge that sometimes the patients won't do as we think. So really, to use the patient-centered approach, I would suggest we need to make sure that the patient has the right tools to deal with their pain. Of course, this ties really lovely into the old iceberg metaphor, where in order to give the patient good information, good advice, we would need to know much more than we are passing on to the patient. So in terms of neuroscience, perhaps, or pain science, as it's called, there will be lots of things that we would have to know about the biology at a molecular level. So for instance, what is central sensitization really compared to what is the theory, what is the metaphor used to explain central sensitization? So I alluded to Explain Pain, the book, prior in this talk, and I would suggest that Explain Pain is a great patient material. So it's really focused on the patient. In this case, it will be the top of the iceberg. It's a way to explain to the patient that we understand what's going on. and that hurt doesn't mean harm, and also that they can train their nervous system to actually become better. But it's not exactly what would be necessary for the clinician to know. I'm referencing this part, so I'm not really putting it on here, but if you want to know more about what would be worthwhile for a clinician to know, I would refer you to either the EFIC, so the European Pain Federation curriculum for pain, different pain professionals, or the IASP, so the International Association for the Study of Pain curricula. Again, the professional curricula would give you a good impression of what is really needed to know. So if we were to move beyond explaining a metaphor and hoping for the best, we would need to help the patient, so advise and also support and remove obstacles for the patient to get back in their social roles, their physical activities, and all of this. As a physiotherapist by background, I'm very comfortable with physical activity. So if my patient doesn't do physical activity, I'm very confident in advising them how to do more or less. What I'm not so trained in, by background at least, is how to get them to re-engage and to be social again. So how to come back into, for instance, a work setting, or get back into social engagements with families and friends. It is my perception that we need to completely stop using the tissue-based explanations when we acknowledge that the pain is non-specific in origin. So if we refer back to the ICD-11 I showed you before, anything on that slide, including, for instance, fibromyalgia or ongoing non-specific low back pain, does not need any tissue-based explanations. I'm not by any means suggesting that we won't ever find a pathology that could explain some of these pains. I'm just saying that at the current state, we really do not know what is causing non-specific low back pain or even fibromyalgia. The only thing we know is that the people who get these diagnoses usually suffer. Otherwise, they wouldn't come to us and they wouldn't have the diagnosis. So that's a logical reasoning perspective. We also need to accept that complexity is the norm. So there are no direct explanations. There's no good evidence to inform us how to do things. We need to accept that we don't necessarily know why things are happening, but we do have the tools to understand what it feels like to be in these conditions. So to interview the patient, to listen to the patient, and to invite the patient to be the expert. And speaking of being the expert, it's really important for us to understand what they perceive is the best part for us to do. So understanding what the patient does and feels is really important to us, because that's the only way we can set the goals. If we don't know what's important for the patient, then how are we going to set patient-related goals? Also, it's important for us to acknowledge that whatever happens during treatment, I'm calling it effect here, it's not a linear response. So it's not that if I use acupuncture on a patient and that patient gets better, it's the acupuncture that did it. It's much more complex than this. But I would definitely use anything that makes the patient better. So I'm not really picky about what I use, as long as I use things that I know are not dangerous for the patient. Or maybe I try to avoid things that I know evidence suggests shouldn't work. So being in the realm of evidence-based practice, there's a lot of things that might have an effect. And I think it's okay to try these out, but we also need to make sure that we shouldn't keep doing these. We should definitely know, if I'm using, for instance, manual therapy on a patient with chronic pain, what will be the prognosis? So how much effect would I expect, and how long would that effect be lasting for, and how would that affect the patient's goal? If my perspectives are not met, so if I think they will have pain reduction, for instance, or increased movement, or the ability to play cards with their friends, and this doesn't happen, then I should be quick to stop using interventions, because basically none of the interventions out there seem to be working so good that we could safely say that we should keep doing them even if there's no effect in the patient. And that also, of course, includes applying and accepting there are a lot of non-specific effects. You might know the word placebo or nocebo. I'm not going to go into these, but I'm happy to respond to those after the talk. So this recent synthesis of findings related to how to optimize pain education has come out in the Journal of Pain. I'll just go through the highlighted fields here. So if I was to use patient education, it seems that it's quite important when you ask the patients that we allow them to tell their own story. And we need to make sure that they feel heard. So the way I use this in my practice is, I can understand that if a patient doesn't feel that my advice is really about them, but it's more like a generic advice, they would be less happy to apply it to their life, because it might be a good advice in general, but the patient, I assume, will be waiting and perhaps contemplating a bit about, but how sure am I? Because I know what I have, but how safe am I if I change something just because my physio told me to? So making sure they get time to tell their story seems to be really important in the literature, and also that's what I find in my practice. Once they've told their story and I have had time to question them about things that I felt were unclear, I think that we're on a much better trajectory to have a good patient therapeutic relationship. Also, we need to understand what the patient thinks is wrong and what they've been taught is wrong. So this might relate both to what have they learned from previous experiences or encounters with the healthcare professionals, but also what's their understanding of what is pain and what's going on. And these things, of course, are very important. And then a really thorough assessment that allows the patients to clarify the story. So if they have elbow pain, they would expect us to understand that elbow pain, but not only from a mental perspective, so how does it feel to you, or cognitive perspective, but equally from a very biomechanical perspective. Does this hurt? And what about this movement? Does that hurt? So they want to feel that we've really done the assessment. There seems to be some suggestion that if pain education is provided by someone skilled in talking about pain, that might have an increased effect. And then final point, if the patient is to use what we tell them, so if they're progressing to a new understanding, a reconceptualization of what pain is, then there has to be some sort of help along the way. It's not enough to just say it once and then they will just use it. They probably have to practice it with us. This quote from Lotze and Mosley is probably, I think, the most the best way to say what is it really to listen. So they say you need to focus your attention on how the patients say things, not just what they say, but also the whole entire, they call it behavioral package. So the way they say it, how they say it, the posture, the body language, how they articulate things, and also if there's anything in their expression, maybe tone, that you could listen to. And then, of course, what they attribute to the words they're using. So there's a lot of things in understanding what the patient says, and it will be essential to any assessment of patients to really go in deep into understanding this. The end goal of many treatment paradigms related to chronic pain would be empowerment. So give the patient the management tools to self-manage, ideally completely self-manage, but even manage partly would be great for many patients to feel less addicted to, or feeling less need to stay within the system of healthcare. This meta-analysis done by Harriet Witting and colleagues has looked at how is empowerment done, and apparently it seems that knowledge, so education, seems to be the most used tool, but it also, from the literature, seems that knowledge should be combined with goal setting, like SMART goals, and some action planning. So a very clear strategy how to use these things. So in terms of pain education. It's not enough to make the patient understand it. We need to make sure that they know why they're doing it, what they can achieve, and what steps they can take. That would the evidence would seem to support that. Another really important message coming out of the same group from Holland is the aspect of health literacy. I've just translated briefly what is meant by health literacy in the top, but I'll go down to the 6 points in the bottom. So the Witting group would suggest that using short sentences and simple words is important. Talking in present tense is better than in past tense. And also using words which are meaningful for the patient seems to be very interesting or very relevant. It would be of high relevance to limit the information. So even if you think there are 10 things they need to know, it might be better to prioritize them and leave only 3 aspects, 3 key points. And then by the next consultation, we could look at maybe 1 or 2 more. And then be fairly specific, or as specific as possible when you talk to the patient. So talking about their condition, their pain, how they feel, what their relationship is much more important than talking about what patients in general do, or what back pain in general is, or how many patients out of 100 feel pain without having any tissue damage, that sort of thing. So be as specific as possible. And also, if possible, use simple drawings or pictures like explain pain or similar things to support the message when you talk. I think it's important also to say that health literacy respect is not about thinking that patients are dumb. I tend to consider myself quite quite illiterate when it comes to, say, accounting or understanding tax, what are they called, tax bills or whatever. So things are just not interesting for me when it comes to numbers and money wise things. I probably could understand it if I wanted to, but it's not really important to me. So if I ask someone to help me do tax returns, I would expect for them to understand that my literacy in the topic is heavily biased by the fact that I really care very, very little about it. And I think we should embrace that patients might feel the same way about health. And we need to keep our professional aspect on that to make sure that we're the ones providing the information to an extent that it's easy for the patient to understand. So just trying to summing up here, we need to make sure that the patient is the expert and that they are able to, so we help them to set goals that are relevant for them. We need to make sure that the patients make the decisions related to their own life, so we can provide them with the opportunities. Hopefully we will tell them something about what is more relevant, what will be the likely outcome of different choices, but by the end of the day, it needs to be the patient who decides what to do. Also, the pace should be set by the patient. So as I talked before, maybe I have 10 things I want to tell the patient, but maybe 1 or 2 things is enough for the first time. And then we would have to build on from that. And very importantly, we need to support the trust. So create trust between the clinician and the therapist. So the therapeutic alliance, some would call it. And also have room to talk about worries and desires. So if you're a prescriber and you use medicine with your patients, it's so important that the patient knows to come to you when they experience side effects. They might think it's normal. They might think nobody has it and I'm just weird. But even side effects from manual therapy or acupuncture could be highly relevant for the decision about whether or not to continue with these medications. But if there's not a room, if there's not place for you and the patient to have these conversations, then it will be very difficult to promote the self-managing strategies. So I just want to briefly talk about the metaphors before we talk about the narrative that I will come into. On the picture here, you see a metaphor. So it's a graphic metaphor of data relating to an MRI study. I'm not sure what the study is about. The picture is just taken straight out of Google Pictures. I'm sorry for not referencing it. I should have done that. But what I want you to take from the picture is that the person lying in this scanner is not a person from the study. They've used the context, in this case, the person with nose, ears, shoulders, to understand what we're looking at, namely the brain. They've used some definition of the brain to see the difference between the different shapes of the brain. And then they've added the data onto the brain to show you what they want to tell you. And this is a brilliant way of communicating because it really makes sense. So one glimpse of that, and you have an impression of what they found. So something is going on that left side of the temporal lobe. Or maybe, what do you call it, parietal cortex. Anyways, the idea here is that using a metaphor is a very, very lovely way to get a message across, to create meaning in some complex data, such as the patient stories. We usually have a theory to read the metaphor. So underneath this, there would be a theory suggesting that this bit of the brain might be related to this or that. And this theory hopefully is based on some solid basic science done in maybe humans or other animals that would suggest that there is some relationship between what goes on in the brain and these perspectives that we are talking about, which could be pain in this case. So basically metaphors are used commonly, and the trick about metaphors is to make complex things seem much easier to understand, and therefore applying to what we talked about health literacy before. These are some of the metaphors I would use in relation to pain. I would talk about the alarm system, so pain as an alarm system. I would also talk about maybe the tequila vaccine. I don't know if you know this metaphor. The idea is that once you've had a whole bottle of tequila, you're sort of vaccinated for the rest of your life. You don't need a whole bottle of tequila again. In fact, if you have just a tiny bit of tequila, you will know exactly why you have it rarely. I would use that to say to the patient that sometimes your pain is started at one point, and at that point something happened in your body. We don't know what it is. It might be related to your nervous system, but what is now going on is that there's sort of a response every time you put yourself in these conditions, which could be stress, lack of sleep, physical activity, or whatever. Also, on the picture 04 would be the princess on the pie, that lovely old story where the princess is able to feel the pea underneath 40 duvets and 40 pillows or whatever that is. And only a princess can do that. To understand sensitivity of the nervous system, that might be one way to go. Or the radar below the nervous system as a sort of not an alarm system necessarily, but a radaring system. So it's keeping track of what's going on, and it responds if something's on the radar. And one of the things I like to talk about as well is the unpredictability of pain. So not being able to predict, why am I in pain? I use the pain like a baby metaphor for that. So those of you who have had small kids, you would know that when a child is crying, you would tend to try and see maybe if they're hungry first, at least if you're a man, because then you could pass them on to their mothers. Or you could try to see if they need to change a diaper, or maybe they need to go and have a sleep. And then the longer they keep crying, the more frustrated you get, and the less predictable the response of the baby. So how to make the baby stop crying becomes. And I think that, to me at least, is a good metaphor to understand the complexity and the unpredictability of some chronic pain that people will experience, or these patients will experience. But of course, when we use metaphors, we need to understand, or to make sure that the patient understands exactly what we mean by the metaphor, not to let them use the metaphor in the way they perceive it in the first place. So teach back would be a method to use here, or simply to ask the patient to tell you what that metaphor is all about and how it might relate to them. So metaphors and theories are not science, and this is a very important topic for me. I won't go into it here. I'll just briefly say that metaphors are, as I said, explanations. They're supposed to make things easy. Theories are then what we use to look at the data, take all the data from the patient, so from the history and the previous experiences of the patient, everything that we hear and what we see from the patient, and then try to make sense of it. That would be our theory. But the science that really should guide us is a systematic and structured collection of data, as I write here, which is then analyzed by a set of rules. So the evidence should be very strict and will have very, very, very strong limitations. So we need to extrapolate it. But if we don't know where we extrapolated it from, coming back to the iceberg metaphor, if we don't know what's underneath the water and we only think of what's above the water, there's very little chance that what we are doing will have an effect, because we are simply just stating the obvious. So you shouldn't move if it hurts or whatever, but really knowing what we're doing at a mechanism-based level requires us to understand the science that lies behind this. Yeah, so we would use in our practice, we would use the placebo effects. Basically, that would be enhancing expectations and increasing learning. And maybe the most used thing, most used theory would be Pavlov's, or the classical conditioning. Exemplified here, if someone takes medicine and they feel great about it and you want them to tamper out of maybe opioids, then in the beginning, just being social or maybe doing exercise together with someone might feel okay, but it's not really doing anything for them. But if you then combine being active with doing the medications, over time you might be able to tamper out only taking maybe placebo pills, or maybe completely reducing that ritual of taking pills. And by the end of a learning period, you might be able to have a response that is similar to what you did when you took the medicine, only by being with friends. I know this is a very simple metaphor. I'm just trying to clarify the concept of classical conditioning. On the other hand, we have this negative response, which is the nocebo response, driven here, as you see, by negative expectations. I won't go into all the details below, but just be aware that negative expectations will, of course, also have an influence on the patient. This study here is just to prove or to suggest how important the placebo effect is. So the expectancy in the upper hand left corner, you see how pain ratings were at baseline in this study. So it's post-surgical pain. And if patients did not have an expectancy, but they got remifentanil, which is an opioid-based treatment, they would have pain reduction that's significant compared to baseline. And if they, beyond that, had a positive expectation, so for instance, they were told that this product they were given were more potent than the usual drugs they were given, then they would have an increased effect. But very interestingly, they wouldn't have any effect compared to baseline if you told them that they're not being given any remifentanil any longer, even though they're still receiving the remifentanil. So if you look at the last one, negative expectancy and the baseline, they're the same. There's no difference between them. So basically, this makes the authors conclude that positive treatment expectancy substantially enhanced the analgesic effect. That would be the positive expectancy. In contrast, negative treatment expectancy abolished remifentanil analgesia, so the pain-reducing effect of opioids in this case. So what we think and how we deal with what we think is really important. And this, of course, has given some good suggestions on how to do it. In the interest of time, I will not go into this, but the slides will be available, and I would definitely recommend nurses and also any other healthcare profession to have a look at this article. So just trying to bring it all together in a narrative. The phone image here is suggesting that the pain we're dealing with is this type of complex nociplastic type pain that if you go on the internet and you read about it, there will be tons of explanations. One of them would be that it's called central sensitization. I'm not really bothered by any of these, as long as we understand that what we're doing is we're trying to create a narrative. We're trying to create a story that makes sense of what the patient feels. So we should try and create a narrative that provides meaning and a way to communicate about how I feel. So how does I as a patient feel? This narrative should also normalize and stabilize their functions. So it should help them understand how to balance their activity levels, for instance. And there should also be some relevance between the contingency plan. So what do I do when I flare up, and my narrative. So the narrative in basics should explain how they feel, why we as healthcare professionals think they suffer and what they can do about it, what we can do about it, but also give them the ability to control, understand, and predict their pain, and very importantly also to find hope. So trying to tie this in together, I think the underlying construct here would be to understand that it has to be coherent. So I cannot give the patient a theory that isn't relevant for the theory. Sorry, I'll try and do that again. When I give a narrative to my patients, I need to make sure that that narrative explains exactly how the patient feels. So it's related to their history, their symptoms, their experience of being in pain. But it also has to cohere with how they've responded to treatment earlier. So if they had good response or bad response, it also needs to cohere to the diagnosis that we're using. And then this narrative explanation should also go straight in or have a direct rational explanation on why are we managing pain the way we should. But more importantly, perhaps, the narrative has to be so easy to use that they can use it when they're queuing up at Nestor's Market or some other supermarket locally. So this would be sort of my proof of concept for the patient. If they can stand in the queue and explain to anyone there within a minute or two how they feel, then I would say this is successful. So just to finish off, I've written out this narrative. It's not a real narrative, but it's inspired by a patient of mine. So it's Karen, she's 47 years old. She's diagnosed with failed back surgery syndrome. And her explanation, standing in the queue at the supermarket when asked, "How are you doing?" she would respond, "I'm doing really well, thank you. Yes, I did have back problems and surgery didn't exactly improve my well-being. I worked out with my GP that there's nothing wrong with my back, but my nervous system has become overactive. It keeps sending signals as if something was wrong, but I'm really fine. I found out that opioids don't really make my life better and that staying active doesn't make it worse. So I've taken up fitness again. It feels great to know that I can safely move. Also, it's really given me a lot of things back that I've given up on, including work. I'm not working full time, you might say, but she's still working or gone back to work. I think that the change happened when I learned that my pain was independent of all the things that I'd learned myself to avoid. I know that the pain would be increased if I go out dancing, but hey, what's life without dancing? So give me 1 or 2 days after dancing and I'll be back to normal. In fact, I'm going trekking in Yellowstone next week. Didn't you go once? So the idea is that after the first time we've had a thorough interview that gives me an understanding of where she is, then I'll pay her back, so to speak, with a narrative that she would go out and use. That is her narrative. It's explaining how she feels and what she's doing about it, and also gives her that ability to try and explain to others what it feels like to be her. Basically, the concept here would be that she can do this 24/7. So every time she thinks, she should be able to reconceptualize the pain, which is different from her going to a class of mine, so a pain class or pain education school or whatever it's called, where she would learn to do it only maybe 3 times a week. So ideally, she would use this metaphor or this narrative every day, every time she feels or relates to her pain, because it should direct her. I'm safe, I can do things now, I'm taking up fitness, it won't hurt me. All of these things are built into the narrative. And then ideally what I wanted to do is start exposing her family to it, maybe her husband to begin with, and then slowly expand it out to significant others, neighbors, colleagues, employer, and really get a feeling of this. And in my experience, over a period of maybe 2 or 3 months, the narrative changes dramatically from what we did in the clinical setting and then what they go out and do. But ideally, the patient will feel more and more comfortable, and the barrier that used to be there, the social barrier, I don't know how to talk about this, people get bored when I do it, people look away, people stigmatize me, I feel isolated, all of these things. If they can talk about how they feel in a way that doesn't intimidate others, but also is descriptive of how they feel, they really have a good tool to work with. And as I said, they can do this 24/7. And that was my contribution.